So why this grading is necessary? Grading, based on the grading, how we need to treat it, like thromboprophylaxis, when we should undergo and how long we need to undergo, this grading will clearly helpful. Any patient who has a total score of 4 or more than 4, we can start the thromboprophylaxis antenatally during the first trimester, and we can continue up to 6 weeks postpartum. Similarly, when the grade is 3 or more than 3, we can start thromboprophylaxis at 28 or more than 28 weeks. And we can continue up to 6 weeks postpartum. Any grading risk factor individually or combination of the grade factors, risk factors like more than or equal to 2, we can start thromboprophylaxis postpartum up to 10 days. Any condition which can cause hospitalization during the antenatal as well as during the purpurum, it may be readmissions, we can consider thromboprophylaxis till the condition comes down. So basically, this venous thromboembolism categorized into 3: superficial thrombophlebitis, venous deep vein thrombosis, pulmonary embolism. Superficial thrombophlebitis is relatively a milder condition where thromboprophylaxis is not required, where we could see palpable vein and there is redness and pain. Simple anti-inflammatory drugs as well as hot compressions will help in relieving it. Other 2 conditions like deep vein thrombosis in the right and left leg, out of which left leg is very common compared to right leg, and 50% of the cases of these DVTs are asymptomatic, out of which there will be some symptoms presentation in few, like there will be a leg swelling, pain, in some there will be a mild uncomfortable feeling like tingling. And whereas pulmonary embolism, one of the high mortality, out of which we see 30% of the cases mortality because of pulmonary embolism. Pulmonary embolism symptoms, we should see palpitations, breathlessness, as well as some kind of pleuritic chest pain. Signs like tachycardia, tachypnea, hypoxia, saturations less than, and pleuritic rub, whereas in few they present with the signs of right heart failure. So diagnostic protocols, there are different diagnostic tests available, out of which few has their own sensitivity and specificity. If you have a high sensitivity, if you have low specificity, and there are risk undergoing this test. If you are non-invasive, if you are super. So there are few diagnostic protocols we need to go to whenever we find any case presented with the deep vein thrombosis, suspected of deep vein thrombosis, pulmonary embolism. Out of which the first blood test, which is D-dimer. D-dimer is like it's a non-invasive test. It's a simple test to undergo, which has a very high sensitivity but low specificity. If D-dimer is negative, we can clearly say that the patient doesn't have any DVTs or PEs. But when D-dimer is positive, pregnancy itself increases the D-dimer, so we can't clearly say that D-dimer can, elevated D-dimer can, we can say that the patient is having DVT. But if D-dimer is negative, at least we can avoid non-invasive tests in such patients. Because of risk of exposure to the radiation, we can decrease at least 35%. Similarly, when D-dimer is negative and compression ultrasound or Doppler ultrasound is negative, the negative predictive value will be around 99%. There are other tests like compression ultrasound, which is cheap, non-invasive, and easy to diagnose DVTs. But definitely in distal DVTs, 20 to 30% cases have been missed, and it is mainly operational dependent. So if it is positive, we can straight away go to the treatment, but negative, even after clinical suspicion, we may need to require or wait for the 3 to 7th day to repeat the test. Or if it is negative and clinical suspicion is high, we may go to some other test like if a patient is like presented with pulmonary embolism, we can do a chest X-ray. Chest X-ray is like a minimal radiation exposure, 0.01, at least 0.01 radiation exposure, because of which there will be no risk to the fetus. But chest X-ray is not a completely confirmatory diagnostic test. If chest X-ray is normal, even after clinical suspicion, we need to go for other tests. Even after it is abnormal, we may require some other test. If chest X-ray is normal, like in pulmonary embolism, if chest X-ray is normal, we may go for a ventilation perfusion scan. Ventilation perfusion scan is good in terms of increased sensitivity and specificity in diagnosing pulmonary embolism, but it has its own radiation exposure to the fetus, which can cause leukemias, chances of getting leukemias. But in terms of breast exposures, when compared to other scans like CTPA, it is very less. So thinking about breast cancers, occurrence of breast cancers, VQ scan is better in compared to CTPA. So we can undergo VQ scan. If it is positive, we can start with thromboprophylaxis, but if it is negative, we can leave that. Or if there is a clinical suspicion, we can, clinical suspicion of the leg DVTs, we can repeat the Doppler scan after 3rd or 7th day. And if if chest X-ray is abnormal, we can straight away go to CTPA. But CTPA is one of the gold standard tests. Similarly, it has a high sensitivity and specificity in diagnosing pulmonary embolism. But however, it has some risk because of the ionizing radiation exposure to both the baby and mother. Similarly, CTPA test, it has a high exposure to the breast, maternal breast tissue, because of which there are chances of causing breast cancers. But when chest X-ray is abnormal and high clinical suspicion, we need to definitely, in view of risk, we need to do a CTPA, where if it is positive, we can straight away start the treatment. If it is negative, we can stop the thromboprophylaxis initially started.